Hello, everyone, and welcome to today's webinar. We'll give folks about 30 seconds to enter the room before we get started here. All right, so I'll go ahead and provide our introduction while folks are entering the room. Again, welcome to this IAS-USA webinar. Today is Tuesday, January 10th, 2023. My name is Jose Francisco, and I'm a project manager at IAS-USA. We are excited to cover today's presentation on addressing challenges in Alzheimer's disease in people with HIV. We are delighted to welcome Dr. Serena Spudich, Professor of Medicine at Yale University School of Medicine, who will go over our introduction slides and moderate our question and answer session at the end of this webinar. Welcome.
Thanks very much, Jose. So I'm really delighted to be able to moderate this fantastic presentation by my dear friend and colleague, Victor Valcour. I'll introduce Dr. Valcour formally at the end of this introduction, but first I'm going to start by going through some housekeeping issues related to the webinar. So these are board members and co-chairs and some of their financial relationships with ineligible companies within the last 2 years, which we'd like to declare. Next slide. The presenter has no financial relationships, and the moderator, myself, has received study drugs from Big Healthcare for a research study. Next slide, please. There is information here provided about obtaining AMA PRA Category 1 credits of 1.25 credits through the IAS-USA, and there's instructions on the website about how to do this. There's also additional credits available for these different types of continuing education modules as people may find necessary. Next slide. There is grant support for the presentation from these supporters listed. And this is important. The on-demand recording and slides from this webinar will be available within 24 hours. And again, here's the actual web link, but people can go to the IAS-USA website and find the broadcast. Next slide. I think one of the key things here is navigating this activity. There will be poll questions, and please choose your response for the poll when the question is posed. You can submit questions for the speaker, which we will be taking and covering in a Q&A at the end of the talk. Please put these through the Q&A button. Do not use the chat button to pose your questions. The chat can be used to have a discussion with other attendees, but for questions for Dr. Valcour, please put these in the Q&A. I will be moderating the Q&A, and I apologize in advance if we can't get to all of the questions. I may also be consolidating some of the questions with similar themes so that Dr. Valcour can answer as many as possible. Next slide. So again, it's my really profound pleasure to introduce Dr. Victor Valcour. He's a professor in the Department of Neurology and Division of Geriatric Medicine. He's director of the Atlantic Fellows for Equity in Brain Health program at UCSF. He's also the director of a postdoctoral program in brain health equity. And for those of you who don't know Victor or have never heard him talk, you are in for an incredible treat. Victor is one of the global leaders in understanding the way HIV affects the brain. He's originally trained in geriatrics. He's also done specialty training in cognitive neurology, so that he really has unique expertise to study aging and the brain. He's also really an incredible expert in the areas of other forms of dementia. And as you can see, he's now really leading a global initiative to understand dementia and training individuals worldwide to understand dementia. So he's really the person who's best poised, I think, that I know that could possibly give a talk that talks about the intersections and the work in HIV and dementia and Alzheimer's disease. And I'll also say that he's an absolutely wonderful speaker, and he's a passionate person who really cares deeply about these issues. So really looking forward to your talk, Dr. Valcour.
Thanks for the kind introduction there. Okay, I think you can hear me okay and probably see my slides at this point. So unless I get a message from somebody that my slides aren't in the right place, I'll just move ahead. So thanks so much, Serena, and the group at IAS-USA for inviting me to give this talk. Of course, it's very timely. Friday of last week, one of our first disease-modifying drugs that shows efficacy has been approved by the FDA for the treatment of Alzheimer's disease, and I think that may really make us all think a little bit about what this means in the kind of work that we do. So I hope to answer a little bit of those questions for you today. So I'll start with a poll if I could. How many cases of Alzheimer's disease have you seen among the people living with HIV that you care for in your clinics? If you could just choose one of this, none that I'm aware of, one, several, or more than a dozen. Okay, perfect. I'm going to go on to tell you a little bit of the learning objectives that you probably have seen. I hope that by the time you finish this talk, you'll be able to describe some of the clinical challenges in diagnosing Alzheimer's disease and other neurodegenerative syndromes among people living with HIV. I think it's one of the more important things that we study at this point because I don't think there's enough understood. Perhaps have some understanding of the more recent outcomes in Alzheimer's disease research, particularly as it relates to new diagnostics that are going to be available, and as well, these new disease-modifying drugs that are coming out on the market. Identify ongoing challenges around the implementation of these research findings in the setting of HIV. So I'm going to ask you just a couple of questions, pre and post, if you could. Patient with HIV asks you about Alzheimer's disease in a routine visit. You inform that Alzheimer's disease accounts for what percentage of dementia among the old in the United States? 50%, 70%, 90%, or more than 98%? Okay, stay tuned. We'll dig into this a little bit. One more slide, this one around HIV, a question. Which of the following statements related to HIV and Alzheimer's disease is correct? A, cerebrospinal fluid biomarkers of Alzheimer's disease are perturbed in the setting of HIV. B, brain structural imaging can distinguish HIV-related cognitive impairment from that of Alzheimer's disease in the clinical setting. C, Lewy body dementia is more common than Alzheimer's disease in people living with HIV, or D, none of the above. Okay, so cerebrospinal fluid biomarkers of Alzheimer's disease are perturbed in the setting of HIV. Gets most of the votes. Let's see what we have. Some of you may have seen this case report. I've used it a couple times. I've diagnosed probably half a dozen to a dozen people with Alzheimer's disease, but this one's quite interesting to me, and I think a good teaching session. So I apologize for those of you who've heard this case before, but I cared for a 75-year-old man, right-handed, with 16 years of education. He sought evaluation for memory challenges because he told me that his brother died of Alzheimer's disease at 79 with exactly the same symptoms that he's having. So as a doctor, you hear those words and they resonate of risk. A first-degree relative with Alzheimer's disease increases his risk, and then he's just telling us, I know what this looks like, doc, and I have the same thing. So a very curious case for me. Subtle, insidious decline in memory for about 5 years, very typical of what we see in Alzheimer's disease, but he remained functionally independent, so that's a little bit slow, but in older people, we can see progression that's that slow in the setting of Alzheimer's disease. Alzheimer's disease has a very, we're not exactly sure, but a substantial preclinical time period, and then a subtle clinical before it moves on to dementia, so this is possible. Medical history is not that large for many of the people I care for with HIV. Some of the typical cerebrovascular risk factors with a heart attack in the past and managed depression. He's been living with HIV now for 40 plus years. His CD4 count at nadir was never lower than 200, which we think is a risk factor for HIV-related impairment. He's never had opportunistic infections. And he's doing well on an integrase inhibitor-based regimen for many years. He's been suppressed for many years. His CD4 cell count's high. So all good markers in terms of his care with HIV. When we do a Montreal cognitive assessment, he has substantial problems, scoring 24 out of 30, which puts him in the mild cognitive impairment range, maybe on the border of early dementia, but typically more mild cognitive impairment. He has difficulty with executive functioning across all three tests, the clock drawing, the cube, executive functioning, and the trails. Surprisingly, he has one challenge in confrontational naming. He can't name the rhinoceros. People where English is a second language or haven't been exposed to these animals sometimes don't get that correct, but this wouldn't have been the case here. And so I worried a little bit about naming ability, which is more typical of an Alzheimer's cortical type of pattern than HIV. And then his memory and learning is interesting to me because he registers only 3 words the first time and 4 the second time, suggesting he's not paying attention well or he's having difficulty with the efficiency at which he's learning what I'm telling him. That's more typical of HIV. And in fact, the words that he learns, he retains later in the recall. So he's encoding, he's making memory, which is the hallmark of typical Alzheimer's disease, that people lose the ability to encode new memories. So in a sense, this is a mixed bag with some things that would suggest more of an Alzheimer's type picture and some things that I see more typically in people living with HIV. His MRI in this case didn't help us. It was read as normal. And in fact, I didn't see anything of substantial interest. So what do you take of this? You're in the clinical environment and you're asking yourself, does this patient have Alzheimer's disease? This is the critical question. What do I do to increase my confidence in the diagnostics here? Do I do more imaging for him? Do I do a CSF assessment? Are there any blood-based biomarkers that I can use that would help me? How about CSF-based biomarkers? I think these are the struggles people are having in the clinic. And I appreciate very much the comments people put in the pre-conference questions about, like, how do I get a second opinion on this? Because I realize getting into clinics, particularly clinics for people who have expertise in both HIV and Alzheimer's, is exceedingly difficult. So I think this is really a crisis we have in what I call geriatric neuro-HIV, what we're seeing in this population of people over 60. But I would take it back out of the clinic room and tell you that there are bigger questions that we can't answer, and they haven't been answered. First of all, is Alzheimer's disease more frequent in people living with HIV? We do not know the answer well. Epidemiologic studies would be needed for that. So we can only speculate. And I will do a little bit of speculating a little bit later in the talk. Will people living with HIV be more at risk for other types of dementia? For example, Lewy body dementia, vascular dementia. Again, this is not something we have a lot of answers to, but we can speculate a bit about both of them. And will Alzheimer's disease present differently or progress differently among people living with HIV? My own experience is that it does, that I do see cases of people presenting with different symptoms that would be typical of Alzheimer's. One person with really remarkable persecutory delusions that end up having autopsy-proven Alzheimer's disease. People that present with mild impairment and progress to death within 3 to 4 years with advanced Alzheimer's disease. So I worry about this, but again, we don't have great studies beyond anecdotal histories like the ones I can share. Let me review with you before we go into the intersection of these two diseases, a little bit about each of the diseases. I'm going to be brief about HIV. I think a lot of you've heard this, but I'm going to try to hit what I think are the most critical things. First of all, the terminology. We've probably done a terrible job with terminology as a group in terms of how we describe the HIV-related injury. I think early on in 1991, with the criteria that were really describing what was happening before we had antiretrovirals, we probably did a pretty good job. We had people with a dementia profile called AIDS dementia complex, very easy to know functional deterioration, progression. It was really, for those of you who recall, very clear. We had a milder form that we called minor cognitive motor disorder, which was very descriptive because it was not only cognitive, but it had a motor component as well. And those criteria were the ones that I adopted when I started my work back in 1999 in this space. But things changed in the late 1990s. We began having access to antiretroviral therapy. And now, we progressed to the point that one pill a day can keep you suppressed. In 2007, a group of people tried to gather and define criteria called the HAND criteria, which some of you have heard about. These have not functioned very well, particularly in the clinical environment, but even in the research environment, we've had challenges identifying biomarkers that link to these diagnostic criteria. We've also had a large group of people who were found in research studies to test with an impaired profile, but didn't have any symptoms. It was difficult to tell whether these people lost insight, which some of our data would suggest that they do have an impairment, but they don't have insight, or whether this is a group of people that may never have tested well. And from the clinical standpoint, it made it really difficult to use these criteria because you were probably claiming more than 50% of the people that had impairment being asymptomatic. And it's difficult when you have a busy clinic and lots to do to realize, to really consider whether it's useful to be defining people with asymptomatic disease. There's some data from some groups suggesting that this is important and may have predictive qualities, but that they've been few and far between. There's likely to be a new diagnostic criteria coming out. I'll just mention it. There should be an article coming out in Clinical Infectious Disease this month that's going to talk more about an HIV-related brain injury. And the framework here will be looking at people who are symptomatic. And the idea is that perhaps some of the people symptomatic will have more of a progressive disease, and some will have more of a static disease that may be a holdover from times when their immune situation wasn't as well controlled, or from damage that may have happened prior to antiretrovirals being available. They'll also consider etiologies to cognitive impairment that are not related to HIV. But these are pending, they're not out, but just to be aware of them. I would say from the 2007 criteria, I do not use them in clinic. They're defined for research. When I see people in clinic, I either define them as having a dementia syndrome or mild cognitive impairment syndrome, and then I put the etiology likely to be HIV. So I'm using more general terms in the work that I do in clinic rather than using these diagnostic criteria. But I did want to bring you up to speed about that. So what is the frequency of cognitive impairment? Unfortunately, this is an area we have not done well with either. You can see estimates among people who are suppressed range from 69% all the way down to 19% in these studies. So it's very difficult for us to understand the frequency of these cognitive disorders. Many studies continue to publish among people who are not fully suppressed, or in some cases, groups that are not on antiretrovirals. From an epidemiologic standpoint, that may be useful. You can define the frequency in a population, but from a clinical standpoint, it becomes less useful because all of you are highly adept at getting people undetectable. And for me, when I see somebody in clinic, I want to make sure they're already undetectable in plasma. Then I can add on, what I can add from that point, because it's very clear at this point that people should be completely suppressed in plasma to mitigate the outcomes, the cognitive outcomes as best we can. To me, what I've seen in my clinic is largely among older people, and my guess is that about 25% to 30% of people living with HIV in old age who are suppressed and symptomatic largely are having this kind of a cognitive syndrome. And that's the number that I tend to think about more, which means the vast majority of people are living healthy without cognitive impairment. And I think that may reflect your own experience as well, or with such subtle symptoms that it doesn't come to your attention. But there is a sizable proportion that do have these symptoms. And I want to tell you what we think is causing this. When people present to me, these are the types of things they often have. Memory is the most common symptom, but we find that in testing, they have impairment across a couple domains. And that may be because we see an impact on information processing speed. And when information processing speed is impacted, all tests can have an impact because a lot of our tests are timed. As well, we see some inattentiveness and error proneness that can make the cognitive profiles a little bit more challenging to interpret. We hear attentional deficits, and you probably hear it as well, in conversations with your patients, if they ask you, for example, about they may mention their memory is not good, you might ask them a little bit about how they read books, how they're watching movies, are they rereading, are they having to watch movies again or rewinding because they've lost some of the plot. These are typical attentional deficits that I see quite frequently in people living with HIV. And as I mentioned, information processing speed is slow. And one of the symptoms patients will sometimes tell me is it's difficult to keep up with rapid conversations, particularly conversations where there are multiple people talking. So this banter that they were really, proud of, maybe these quick quips that they could respond to and be part of the conversation, sometimes they're finding it more difficult. And in my experience, people will report some days they feel great, some days they don't feel great, and even weeks are good and some weeks are not. And I think this is something I've learned to be a little bit more typical of people living with HIV, this kind of ongoing level, but with some fluctuation. And we don't really see people progress to dementia. It's very infrequent among people who are treated and have suppressed plasma viral load. HIV can affect cognitive, behavior, and motor domains, so we try to take a large inventory of looking at the different aspects of cognition, as I mentioned, concentration, attention, mental slowing, but also memory. And we have good data that suggests the virus itself can contribute to behavioral changes, particularly those around anxiety and depression. So we take those in as well. And we look at motor findings. In treated HIV, we don't see a lot of motor findings, but untreated, you absolutely do. A lot of Parkinsonian findings. And even among treated people, we can find it in statistical studies and in research studies that there's an increase in Parkinsonianism, but you probably wouldn't notice it so much in your clinical evaluations and day-to-day. But if we do a real careful exam, we can find sometimes increased tone, a little bit of tremor, subtle findings, slowing and rapid alternating movements that look Parkinsonian in appearance. One patient I saw who had untreated HIV and Alzheimer's disease in his 70s, when we treated him for HIV, his Parkinsonian symptoms went away. His gait speed opened up, his hypomimia and hypophonia, so the movement of his face, the softness of his voice, they went away. Really, these cases tell you a lot about how diseases can progress. You'll hear a lot of people say that the cognitive impairment in HIV is due to vascular disease. I'm not a believer, but you need to also know that there is substantial cerebrovascular disease among our older people living with HIV. This study here, an autopsy study, showed that in people with relatively young age in the early 2000s, there was a lot of cerebrovascular disease. 50% of people classified as having moderate to severe. And when we look at images among people who are older living with HIV, we see some of these very bright white matter changes that link to cerebrovascular disease. The challenge is that they do contribute to some particularly executive functioning tests on our studies, but they're not sufficient to explain the cognitive impairment that we're seeing in the setting of HIV. And if I saw these images alone among people not living with HIV, sometimes they test perfectly normal on cognitive tests. This is getting to the point that I might begin to think there's a singular vascular problem, but most time when I see images like this, I think of vascular contributing to something else that's underlying, usually Alzheimer's disease. So we can think about cerebrovascular disease more as an unmasking of a neurodegenerative process in older people living with HIV. So that if you have the two, you're much more likely to present with clinical symptoms. And there's some very nice studies pointing that out. I think HIV is probably similar, that if you have an HIV-related impairment and you have vascular changes, you're more likely to be clinically symptomatic. And that's one way to kind of frame the cerebrovascular contribution. These are a little bit busy slides, but essentially pointing out that we see more white matter burden in people living with HIV and that they link to cerebrovascular risk factors. So they're probably related to cerebrovascular disease. My guess is probably an interaction between HIV and cerebrovascular disease, particularly in early untreated HIV, where there's probably perivascular inflammation from monocytes and the vascular injury from things like hypertension, and smoking may have had a combined approach. The big thing I want you to know, and you've heard me say this before if you've heard my talks, is that there's absolutely no doubt that among people who are treated with HIV and have suppressed plasma viral load, that there's a contribution of inflammation to the cognitive syndrome. And these two bullet points will point that out. One of my favorite studies was a PET study using positron emission tomography, using a ligand called TPSO that binds microglia. So if you have more binding, you have more microglial activation in the brain. And what this group found is that among asymptomatic, healthy, cognitively normal, cognitively testing normal, individual working, living in the community, that as a group, they found more microglial activation than healthy controls that were enrolled, I believe, from STD clinics so that they were demographically matched. What's more is the amount of binding inversely correlated to performance on executive functioning, even though they tested normal. So there's variability in the testing, and there was an inverse correlation. To me, this is just very strong evidence. And we've also seen that monocyte-based markers link to cognitive performance, and these monocyte-based markers are measured in blood. We did a very nice study looking at monocyte-based markers and this imaging modality called DTI that looks at the integrity of the brain. We found clear correlations with the amount of inflammation measured in the blood and DTI abnormalities, and those DTI abnormalities linked to performance on cognitive tests. So, and these are older people over 60, all suppressed for a period of time. So I'm absolutely convinced that inflammation, particularly among our older people, plays a role, and that's a critical message I'd like you to hear. We also see in older people that there's an accelerated brain atrophy compared to very healthy age match and gender matched controls. To me, this speaks to a reserve effect on the brain, and that there may be lower reserve among people living with HIV. And as a consequence, they may be at more risk for other neurodegenerative syndromes. Okay, key points. Frequency estimates are hard to come by with HIV. I will say in older people, 25 to 30%. Younger people, I'm not sure yet. I think us treating people so early on in infection may be mitigating some of these cognitive problems long-term. But these are questions both Serena and I are trying to answer in some of the work that we do collaboratively. I would say, even though we see this progressive atrophy in older people, clinically, I don't tend to see progression. Patients will sometimes feel they're getting worse. In fact, commonly would tell me year after year that they're feeling more symptoms. But in testing, I don't see a lot of changes and often see some fluctuation. So perhaps there is some progression, but clinically it's not broad. It's not really profound. Although I acknowledge from the patients that they certainly do see these changes, and there probably is some progression, but on our testing, we don't see a whole lot, of that. Among younger people, as I said, we don't know, and vascular injury is not sufficient to explain, although I agree that there's contributions. Okay, let me switch completely to the other end and tell you a little bit about Alzheimer's disease, another area of work that I have in my clinic. These are the classic pictures drawn by Alzheimer's back in the 1960s of the first case diagnosed. You may have heard about the first case more than 100 years ago. We've been living with a disease that affected here a young person with a progressive neurodegenerative syndrome that died with a profound dementia, and diagnosed at autopsy identified some of these plaques and tangles that you may have heard in Alzheimer's disease. Let me start by telling you, first of all, if I can get the slide to go, that dementia is really a syndrome. If you say somebody has a diagnosis of dementia, you're basically giving a syndromic definition that begs the question, why? And so in our work in clinics, we say a dementia syndrome because of some disease. Many times we don't know exactly what it is, so we might say unspecified at the time. And I think that was one of the questions that came out. But the dementia syndrome, particularly in neurodegenerative syndromes like Alzheimer's disease, probably began years before anyone comes to us with any symptoms. So the preclinical component, this part that here is called cognitively unimpaired, has increasingly been recognized in the Alzheimer's field as an area perhaps of interventions. If we can identify the people that have these early signs, these early changes that will progress, can we halt the progress of this and prevent dementia? Likewise, mild cognitive impairments, when people are having very subtle symptoms, but they're still functionally independent. The real difference of what we call dementia is when there's functional compromise. So when people are having difficulty with their IADLs, ADLs, they pivot from either an unimpaired, cognitively asymptomatic, mild cognitive impairment, they pivot into a dementia. And among dementia, you can have mild, where you're still able to do many things, to moderate, where you may require some assistance, to severe, where you're requiring a lot more assistance. So what are the etiologies to dementia? Well, there are dozens of them. The most common ones that you'll hear of your clinic is Alzheimer's disease. And Alzheimer's disease, according to the Alzheimer's Association in the US, probably accounts for about 70% of all dementia that we see in the United States. Vascular contributions, even the Alzheimer's Association, I've changed their slide ever so slightly because they gave estimates that were a little bit higher. Pure vascular dementia, we don't see a lot in the United States. These may be people that have had a large stroke or a stroke that's really strategically placed that affects their ability to make memories, or people who have had substantial contributions from small vessel ischemic disease with some of the images that I showed that begin to have an inefficiency in thinking that usually will progress slowly over time unless there's a second process. So as I said to you before, even when I see the vascular burden of the prior slides where I was showing those images, if somebody's coming to me with a progressive symptoms in the past 2-3 years, I'm quite worried there may be two things going on, which in people over 80, 2 or 3 things is not uncommon in terms of what's happening in the brain. Lewy body dementia is a dementia you may have heard a little bit about. This has more Parkinsonian features. Its hallmark are hallucinations, particularly the Capgras syndrome, where you think somebody is not themselves, a replica of themselves or a replica of their house. And then in people under the age of 60, the most common dementia is actually frontal temporal lobar degeneration, which can affect the frontal lobes and cause a lot of behavior changes, but also can have a temporal lobe presentation that's much more language dominant. Nearly all the dementias increase with age. Frontal temporal dementia, as I said, is more common in younger age. Pure vascular disease is not common. And mixed pathologies are so common in old age that we, even who are specialists in this, do a terrible job describing exactly what the pathology will be. People that work in specialty centers of people over 90 are accurate on the diagnosis at autopsy only about 50% of the time. So we have a lot of things that are contributing to cognitive impairment in old age. I apologize for this busy slide, but what I really want you to know is that these diseases, Alzheimer's, frontal temporal dementia, Lewy body dementia, they all have specific proteins that we find in the brain that are depositing. The ones that you're used to is A beta 42, A beta 40, so the plaques that you hear about in Alzheimer's disease, the tau, which you may hear about, the tangles that we hear about with Alzheimer's disease. But even in diseases like frontal temporal dementia, we find various proteins that are deposited in the brain are probably engaged in the disease process or a hallmark of something that's happened in the disease process and are useful in helping us to try to address these diseases. In fact, some of them, and this slide doesn't have progranulin, which is another protein that we see, we now have disease-modifying targets for. Alpha-synuclein is the most common in Lewy body dementia. And in red, I put down here that, I'll point out to you later in the talk that many of these proteins have been found in the brains of people living who died from HIV, but typically in the pre-heart era, and usually not in the forms that we see. So we see, for example, diffuse plaques in people living with HIV, these A beta plaques. But the hallmark for Alzheimer's disease are neuritic plaques, which they have not been described. And in fact, the PET imaging that picks up neuritic plaques has not been seen in HIV. So there's a real mixed bag of these proteins being higher in the brains of people untreated, but not yet triggering off into the kind of processes that we're seeing with HIV. Nevertheless, a little bit worrisome, I would say, and I'll tell you a little bit more about that later. In Alzheimer's disease, which I'm going to largely talk about, amyloid is only one of the proteins that is present. And this is an interesting case I just learned about last month, and so I felt like I had to put it in here. A good friend of mine, Francisco Lopera from Colombia, who runs one of our studies in Medellin, Colombia, where there's an autosomal dominant Alzheimer's disease with 100% penetrance. What happens in this community is people that are born into this kindred develop dementia in their 40s, and it's really affected the entire community, where early signs of dementia are recognized by family members. Mothers are taking care of sons who have Alzheimer's disease, a real flip of what you would typically see in the more sporadic Alzheimer's disease we see in the United States. But this is a very interesting concept with this 100% penetrance. Augusta was the first person described with Alzheimer's. You saw her picture before. And Illyria, who never developed dementia in life and had this presenilin mutation, but had a second mutation that prevented the deposition of tau. And you can see here a typical tau with this really bright red. But then in Illyria, the tau was very limited just to the occipital lobe, and surprisingly, she didn't have any occipital symptoms. But in this case, she somehow was prevented from developing dementia because the tau didn't move forward. So this is helpful for us in understanding the disease, and a very interesting story out of Colombia that I wanted to share with you. So really, these two proteins are what's necessary to progress to Alzheimer's disease. The epidemiology of Alzheimer's disease, I think you're all aware of. There's this so-called doubling effect that every 5 years, the prevalence goes up by twice as much. So at 60 years, it's about 1%, by 65, 2%, by 70, 4%, by 75, 8%, and you can follow through. So there's this curve that goes up in terms of the frequency that you can expect Alzheimer's disease. Now, this is important because in your clinic, you probably have less than 5 or 10% of your patients over 70. So the frequency of Alzheimer's disease is going to be much less. In your 60 to 70-year-old, maybe 2 out of 100 will be likely to have Alzheimer's disease. So if you're seeing 100, you might have a couple cases. It makes it very difficult for us to understand from an epidemiologic pattern what we can expect in Alzheimer's disease, because it would require a multi-center study to understand the epidemiology, because there aren't enough cases in one setting alone. Now, this is a population on this talk, a group that's from around the state. Take a look at your state here. How high can you expect the numbers to increase in Alzheimer's? This is an epidemic in the United States, largely because of aging, but also because a lot of the contributing factors, and particularly the cerebrovascular factors that can potentiate the clinical presentation of Alzheimer's disease, is going up. But we really are expecting huge numbers of people living with Alzheimer's disease. And if you're living in a state like Florida, Georgia, Arizona, Nevada, you can expect these increases to be much more, largely because your populations are aging. So this is an issue you will be seeing in clinical practice. Not surprising to you, the Alzheimer's Association is publishing out the frequency of death due to Alzheimer's disease compared to that of HIV. This is a slide that I stumbled upon trying to prepare for this talk, but I don't think any of you would be surprised at this number, and this is the number that's going there. So we are looking at different priorities. We have in the Alzheimer's field, and perhaps many fields, we have a challenge around underrepresented minorities in research. There's quite a bit of data epidemiologically suggesting that African Americans are at higher risk for Alzheimer's disease. But when you really look at the issues, it's not a race issue. It's a social determinants of health issue. It's access to healthcare, access to education, access to treatment for stroke, access to treatment for hypertension. But we really, if you look at the studies here at the bottom bullet point, I pointed out less than 5% of those enrolled in the big imaging study called ADNI were African American. And they had to launch an entirely new study. The original study was called the IDEAS study. And they launched a whole new IDEAS study because they did such they're unsuccessful in getting non-Caucasian populations enrolled. There's also something interesting about women. 2/3 of Alzheimer's disease in the United States is reported in women. One of the challenges with these data are that women live longer. And I already showed you that age is a big contributor to neurodegenerative syndrome. So some of it, at least, is taken up by that. But there are a lot of people advancing hypotheses that explain other reasons for this that are beyond today's talk. I mentioned to you already these proteins that are deposited, and it's really quite important because we use this to understand disease in at least in a research setting, and sometimes in a clinical setting. So we will often order and sometimes get it reimbursed amyloid beta 42 and tau levels, and the ratio of that can help us to understand whether a person is high likelihood of Alzheimer's disease or very unlikely. And also this tau 181 has been used in research studies as well. The point that I wanted to make with this slide is that I've talked about this before. This green area is where you're having symptomatic disease. But what we think is happening earlier in time is that there may be changes in some of these biomarkers that may help us with early diagnostics in a pre-symptomatic Alzheimer's disease situation. But then as it advances forward, eventually there are changes. Even MRI may change well before we start seeing the clinical presentations of the disease. It describes this opportunity to prevent disease if we can identify people who are in the pre-symptomatic stages. That's rather unique to where we are in the Alzheimer's world now. The reason why this might be interesting to all of you is that there probably will be a blood-based biomarker that you can order in your clinics in the next 12 months. We're seeing lots of highlights of this in the news media, and there are several markers that are really likely to advance. One has been a plasma level of this A-beta 42 to 40, and you can see it does distinguish, but for you who are not specialists in the field, I would realize the overlap here because there's a substantial amount of overlap, even though you have a sensitivity and specificity of 7.77, 0.78. So what this will mean in your clinical practice is you want to apply this very carefully because the likelihood of false positive or false negative is high. This may be more useful in specialty centers. And as well, it will help you to understand if the biomarkers that are connected to Alzheimer's disease are there. But if you have a neurodegenerative syndrome and the Alzheimer's markers aren't there, we automatically begin thinking about other neurodegenerative syndromes that could be presenting as a phenotype looking like Alzheimer's disease. Sometimes Lewy body dementia can present without the frank hallucinations and look more like Alzheimer's disease early on. Even some of the more tau-based diseases like corticobasal syndrome, we can sometimes see with this. So in specialty centers, we think about this more as kind of helping us clarify the diagnosis, but it's worth your knowing that these are going to become available. Here's some of the data again showing how the biomarkers work towards amyloid PET. Does the patient have the amyloid plaques is basically what they're saying. Do they have the tau that you need to see for progression of Alzheimer's disease? And there the curves are quite impressive. So some combination of tau 181, 217, 231, or neurofilament are likely to come out in the next year. And there was a question asked to me before about neurofilament, and I would say there's quite a bit of work looking at neurofilament. It seems to be more non-specific, but correlated to neuronal injury. So it does have some, potential use in both Alzheimer's disease as well as HIV. And then the last thing I'll point out is that I think second to last, because I think I have another slide here, but we do have symptomatic treatment for Alzheimer's disease now. We tend to use cholinesterase inhibitors. The benefits are, I don't even want to say modest. They passed FDA. They have a statistical significance. In my clinical practice, I use them all the time. And at the same time, I'm never wowed, seldom wowed. Alzheimer's disease particularly, but in Lewy body dementia, particularly with fluctuations, I have seen benefit from using these cholinesterase inhibitors. The other drug, the NMDA receptor antagonist, memantine, I have to squint real hard to understand how that got FDA approved, but I do use it in clinical practice, particularly for people in moderate degrees of Alzheimer's disease who are already doing well on cholinesterase inhibitors, which is really the only area that they showed signal, moderate to severe Alzheimer's disease in people on cholinesterase inhibitors. But the real exciting thing, and what you may have heard over the weekend, it was in the New York Times on Friday, is that we now have anti-amyloid therapies that are FDA approved. Conditional approval for lecanemab last Friday. The conditional approval is pending further review of all the secondary outcomes. We think they'll probably have full approval soon, probably by the end of the summer. And this is the first time we've had a clinically relevant, that you may have heard all the controversy about aducanumab, Alzheimer, which there's a tremendous amount of controversy among the dementia field about whether this should be approved. But this lecanemab is much more clear, showing efficacy, seemed to affect both tau and amyloid outcomes, and showed a very small, again, we don't know what word they use, modest. I'm not sure modest is right. Mild, scant, but some efficacy, but with change in disease markers on films, which really pushes the proof of principle around the amyloid hypothesis and has advanced the field tremendously, despite what may be a limited impact on our patients in the short run. Why a limited impact? There's still a lot of controversies. First, there's a lot of controversy about the scale of the benefit. Is it enough for a patient to go through the treatment, which is going to be an infusion every 2 weeks with frequent monitoring of MRIs, because it has a substantial risk for these amyloid-related imaging abnormalities, which cause swelling and bleeds in the brain. So these are going to be these interventions will be done in specialty centers and with a lot of monitoring and a fair amount of burden on patients, which, there's no better audience than this audience to talk about what patients are willing to do when they realize they're going to die if they don't do anything. So we all have to have a lot of empathy about individuals who have a disease that is going to progress. And now we have a therapy. So I don't want to impose my opinion upon this, but it seems like a lot, but when you have nothing, people are willing to do it. So we'll see, how the uptake of this will be. Most studies require expensive tests to get in, and this one will require that you are demonstrated amyloid. So Medicare doesn't cover amyloid PET right now, but they're probably going to pivot to cover it if they're going to approve this for treatment. Right now, we're quite a ways away from whether Medicaid will cover this. It seems that it's covered now in the current guidelines, but those guidelines require that there's a clinical study oriented with the medication. So there'll be a lot of changes in the next six months that you can stay tuned. If you're really interested in this topic from a primary care perspective, hit this link down here, a nice review. This is the Jerry Powell group at UCSF, a bunch of geriatricians really arguing, is this worth it? What are the risks? I think it's a really nice podcast. It takes about 30 minutes to listen to. You'll get a kind of a primary care perspective on these medicines that may be useful for your clinical practice. And then my last slide is, should we be treating these modifiable risk factors, the social determinants of health? Absolutely. The Lancet Commission tells us that if we treat all these things from hearing loss to hypertension to obesity, we'll decrease the clinical manifestations of Alzheimer's disease by a substantial amount, decreasing all dementias by 35%. So I'm very careful with the way I worded that. I'm not saying that we're going to get rid of Alzheimer's disease, but I've already told you that people that have both cerebrovascular disease and Alzheimer's are more likely to have clinical symptoms. So if we can decrease the burden of the cerebrovascular component, we may have people that will live a couple of years without clinical symptoms, even though they may have some pathology if they were to die. When you're 90 years old, 2 years is a long time, and you may prevent a dementia in that individual. So these are things we all should be thinking about and optimizing for our patients. Okay, let me move into kind of the most speculative part of anything I can say today, and please accept that these are my speculations. As I was preparing this talk, I was going through old slides and pulling things, and I don't know if you guys recognize this young man in this picture, but it was me almost 25 years ago, I guess 2002, so 20 years ago, seeing a patient living with HIV who was in her 60s and was living with a cognitive syndrome. And when I asked her, the paper wanted to do a story on our study, and I said, they want to talk to a patient. I can't imagine you want to talk to the paper. She says, absolutely, I want to talk to the paper. I want to be on the front page. I want every woman to know that they're at risk for Alzheimer's, for HIV. So she was on the front page of the Honolulu Advertiser many years ago. Anyways, so what do we know? More questions than answers. Whether the course, features, and timing of onset are different in HIV are really not known. We need epidemiologic studies to say this. My speculation is that there will be alteration based on the few cases that I've seen, and the fact that I think there's decreased brain reserve, there's cerebrovascular disease and inflammation. All of these things are not the best environment on which to have a neurodegenerative process superimposed, and so I worry that there could be, some higher concerns. There's insufficient evidence to know if other forms of dementia will be more frequent, but it's very unlikely. 70% of 70% of dementia in the United States is Alzheimer's disease. Lewy body dementia, much, much less. We're not going to see that flip, I don't think. So we're probably going to still continue to see more Alzheimer's disease than any other type of dementia in people living with HIV in old age. But we don't really know those answers. As I said before, the biomarkers and pathology are suggestive. There have been multiple studies in the pre-CART era mostly showing that there's amyloid. Diffuse amyloid, they've measured as soluble amyloid and diffuse plaques, not the neuritic plaques of Alzheimer's disease. So we know in a couple reviews that you can look up here that that's been seen. We've also seen TDP-43, which is seen in frontal temporal dementia in some papers, and this was reviewed in 2008. Even alpha-synuclein that we see as a protein deposition in Lewy body dementia, and here's a review for you. And then to me, the biggest thing is this decreased brain reserve. At least in our studies, we see progressive atrophy There are a couple studies that didn't see progressive atrophy. One study excluded cerebrovascular disease, making us wonder if the atrophy we're seeing is all due to cerebrovascular disease. We've done a follow-up study to show that that only captured about a third of the variability, so something else is happening. But most of the studies were in younger people. So maybe there's something about our population that's over 60 where we're seeing a little bit more. So there's some more questions there to be answered. And inflammation, of course, is worrisome to me. Here's the study showing that there's more diffuse plaques. This was done by Lynn Pulliam here at UCSF back many years ago, 2005, this was published. And she even found that in vitro studies, this protein neprilysin is inhibited. And as a consequence, it may be neprilysin is involved in amyloid pathways, and maybe that's the mechanism by which that would occur. Boansis published that in people living with HIV, we don't see more neuritic plaque. This is a PET scan done with the Pittsburgh protein, and he didn't find it in any people in the age of 47. So that's reassuring. A small sample, younger people, probably a safer sample because amyloid positivity increases with age, even in the absence of disease. So not finding it in people 47, I think, would match with the clinical environment. He also showed that the tau imaging was not different. So those are both encouraging, but among younger people. And I've talked a little bit about the PET imaging a bit, because you might think, well, can we get amyloid imaging on people to distinguish them as HIV versus Alzheimer's? The challenge is that there are quite a few people walking around with positive amyloid scans for years and don't present with Alzheimer's disease, and that rate goes up with age. So by the time you're 70, you can expect about 20% of healthy controlled with no symptoms to have a positive PET. Now, we think they're at increased risk for Alzheimer's disease, but as I mentioned to you before, we need the tau as well, and so that's probably what's going on. We have done quite a bit of PET imaging using florbetapir, which is another compound, and we're not finding rates in people over 60 that exceeds that which would be expected in the clinical population. So at least in our small unpublished work, we're not seeing high rates of amyloid positivity outside of what we'd see with healthy controls. And I would say clearly excluding a few people that I was confident had Alzheimer's disease in these studies. Right now, PET scanning is not covered by insurance, and at our center it costs $4,000 to $5,000 for a PET scan. So that may change in the next year, but it's clearly a barrier. Okay, I got to run. I didn't realize I was going to go quite so late. This is a study showing that there's perturbations in CSF amyloid, and so it doesn't track on well with PET scanning. This is something I've already told you, that we do see perturbations of CSF amyloid in the setting of HIV, so you can get that question right at the end. Very early data from Bruce Brew showing exactly that people with Alzheimer's disease in later stages particularly had levels of amyloid that were very similar to that seen in Alzheimer's and much lower than that of controls. Again, early HIV, sometimes without treatment, and this is another study from Bruce Brew showing exactly the same. I mean, from Dick Price and Serena Spudich showing the same thing. There was one small study out of Edinburgh looking at only about 10 people that showed some increased tau in particularly the medial temporal lobes of people living with HIV. This study had some caveats in that people died on antiretrovirals, but we didn't know if they were treated. There was also an unexpectedly high rate of people with other infectious diseases. So speculative at best at this point. Okay, so the intersection of HIV and Alzheimer's disease, only 5% of Alzheimer's disease is known to have a genetic cause. The rest is sporadic. So there's a lot that we don't know around Alzheimer's disease, but a lot of opportunity in terms of whether environmental factors that are increasing Alzheimer's disease. If so, will the setting in HIV, the environment of inflammation contribute to this? Multiple unproven hypotheses around environmental exposures, including viruses such as CMV and herpes simplex virus that may be more frequent in our population, that also increases the speculation. Most data presented are captured in earlier HIV stages, so we don't have a lot of data on treated. And then, as I said, the brain reserve hypothesis is what I think about more. So back to our 75-year-old, what would you do? I'm going to skip this slide, but leave it in the slide deck for you. It's just a summary of things because I'm going slower than I thought. Imaging is something that I thought would be really helpful. From the naked eye and in the clinic, it doesn't seem to help. Even among some of our doctors that are experts in Alzheimer's, I show them an image of somebody who is amyloid negative, does not have Alzheimer's disease, but is living with an HIV impairment. And I hear from them, wow, that looks just like Alzheimer's disease. But the machine learning algorithms are a little bit better at this. And this is an area of research that maybe we can develop an app that you can upload your image and it'll give you a likelihood that this is due to HIV versus Alzheimer's disease. So what do we do next for this individual? Well, all of these are wrong. I wouldn't modify antiretrovirals for greater CNS penetration. We didn't go into that today, but there's not much evidence that you can improve people with HIV unless they have an unusual syndrome of CNS escape by changing their antiretrovirals. I don't use cholinesterase inhibitors in people unless I'm pretty sure they have Alzheimer's disease. So I wouldn't do this empirically in this person unless I knew more clearly that they had Alzheimer's disease. If I follow this individual for another 2 or 3 years and they decline, I'll be more likely to think it's Alzheimer's disease, but we will have waited 3 to 4 years. So this is a crisis. We have to figure out a way to do this. And I would tell you right now, CSF assessments are somewhat helpful, and we tend to do it in specialty centers or seeing somebody who specializes in both of these diseases. Okay, so what did we do with this individual? I was able to get him a research PET amyloid for free, and it was negative. So I was confident that this person did not have Alzheimer's disease. I've since followed him longitudinally, and he's following a typical HIV-related pattern with some fluctuation, largely stable, and no change in his functional status. What can you do now in your clinic among people living with an HIV-related dementia? First of all, adherence to medicines is key. Put them on a regimen that they can tolerate and suppress plasma viral load. If you're worried about Alzheimer's disease or rare CNS escape, develop networks within your systems where you can refer. If you're not comfortable yourself, and I apologize that that's a terrible thing for many of you to do. It's very difficult to do, and I appreciate that. But trying to develop those networks is going to be helpful. Try to treat polypharmacy as much as you can. Try to address the social determinants of cognitive brain health in your populations. Most of you are doing this incredibly well already. Double down on it. Talk to our patients about compensatory measures, since there's a large attentional component to what's going on. Using lists, using reminders are helpful. If they're comfortable disclosing to friends, that may help them engage more in society and stay socially engaged. In my experience, most patients are living with a stigma of HIV, and they're not ready to live with a stigma of a cognitive disorder. So this doesn't tend to go far. Reassure them that they're not alone, and that the trajectory in an HIV-related impairment is likely to be fluctuating but relatively stable, and empowering them that this occurs among other people. So I'll close, and then, sorry that I'm going longer than I thought, but some summary points. Impaired cognition remains important, a frequent challenge in the current era. It probably affects somewhere between 25% to a third of our patients with successful plasma viremia. And I showed you evidence about inflammation being a concern of mine, probably multi-etiologies to the cognitive impairment. Yet we have to realize that our patients living with HIV with suppressed plasma continue to have influences of inflammation. The sources of that, I think, are HIV, but there are other theories as well. Cerebrovascular disease is common, but not likely to be the only etiology to cognitive impairment in old age. We have to expect that we're going to see more Alzheimer's disease as our patients age into their 70s and 80s. It's an urgent question for us to do a better job distinguishing the two. Don't feel that you're struggling with this any more than even our center. The patient I presented to you, I used because I struggled with it. I pointed out features that were suggestive of each, and in the long run, I was able to get a test to confirm that he did not have. So I even struggled with this in the clinical setting. The neuropsych patterns are helpful, but not sufficient. And biomarkers may be, helpful, at least in excluding Alzheimer's disease. You still have to think about the other forms of neurodegenerative disorders in people living with HIV, but with Alzheimer's being the most frequent, it may have some help. It is important to follow emerging reports in Alzheimer's disease research. I encourage you to listen to the podcast, be familiar with this stuff. It's likely these changes are happening. It's one of the most exciting times in Alzheimer's disease research that we've seen in decades. The availability of blood-based biomarkers and disease-modifying drugs, even with all the caveats, is really an incredible step forward in our ability to combat this growing epidemic of people living with Alzheimer's disease. And a lot of the work will require work within people living with HIV. One of the questions, that came in before this talk is how well will these markers work in people living with HIV? I've talked to some of the experts who study this. I think they'll work. The thresholds may have to be a little bit different. It's an area that needs a little bit of research. Okay, I think that brings us back to the questions. A patient with HIV asks you about Alzheimer's disease. How awake have you been during this talk? What's the frequency of Alzheimer's disease among older people living in the United States? Waiting for those last votes to come in. People are waking up. Okay, much improved. The Alzheimer's Association recommends or has published that the rate's between 60 and 80%. So there's quite a bit of variability. 50 is not very far off. 90 is probably a little bit high, but it's probably around about 3/4 of the people of the diagnosis in the United States. So the last question here, which of the following statements related to HIV is correct? Cerebrospinal fluid biomarkers are perturbed in HIV. Brain structural imaging are useful clinically to distinguish Alzheimer's from HIV. Lewy body dementia is more common, or none of the above. Which would you choose? Good. Yes, the best evidence we have is that cerebrospinal fluid is perturbed even among our patients that are treated and suppressed. About 1/3 of the time we find either a low amyloid or a high tau, and the report back from the company says that this is borderline. And knowing that this person's living with HIV, I have to interpret that. So these equivocal outcomes are common. But in most people, over 50%, we get a pretty clear answer. So I tend to use it. Okay, with that, I'll close my talk and hand this over to Serena. I'll stop sharing.
Oh, fantastic talk, Victor. You could give a masterclass in how to give a great webinar, and also making two very, very complex topics clear. And I think talking at the end about your speculations about how they go together is really, critical insight that only you can give. So I think, it was a really fantastic talk, and there's a lot of really positive comments in the Q&A. Thanking you for the great talk. I believe we have about 12 minutes for Q&A until the end of the webinar. And so what I'm going to do is actually go through, you have many, many questions here. Perhaps these can be saved for you to actually review later, because I think they may be informative to you and interesting. I think what we should maybe start by focusing on are some of the clinical questions. And there are several questions that are on a theme of primary care in the office, screening, these kinds of things. So there's one question that asks, what are the best bedside evaluations to start with? In your example of your case, you used a MoCA. There's another question that asks about this too. Is that what you always use in your clinic? Are there other things at the bedside that you would use for screening for these kinds of indications?
Yeah, so I don't screen because I'm not a primary care doctor. So when people come to me, I'm doing diagnostic tests, and we tend to use the MoCA as a global diagnostic test. And in fact, the data you're seeing were from a research study asking me how often can you pick up what we see in neuropsych testing, a 1-hour battery, when you do what we found to be an 8.5-minute battery, the MoCA. And we showed that you had modest performance characteristics. I think the area on the curve was not fantastic, about 86% sensitivity. Mm-hmm. And so it's not a great test. It takes a little bit of time. In our hands, I said about 8 minutes. So I don't know how well as a screening tool it would work. When I talk to audiences that are largely caring for younger people, And we really look at the United Prevention Health Task Force, whatever that is, the EUPH. And I've published, I think, 3 papers on this topic. So none recently. I think the last one has been a good 5 years. But if you really look critically at what they say, like how well do you have a test that works well? What's the evidence that you can affect outcomes if you test people and you identify it? What's the evidence that you have therapies that are going to work for them? If you really go through those steps, you'd be scratching your head to be doing screening in your clinic. But that's a very formal and high bar to get to how you do screening in clinic. On the other end of the spectrum, you're working in a clinic where this is a common thing. We're thinking about geriatrics and how do we better care in a multifaceted geriatric setting. And if you're going to look at all the geriatric syndromes and you're ignoring dementia, you're ignoring the one that is the highest risk for nursing home placement because of incontinence, usually because of dementia. So if you're looking at outcomes, you would think that you would want to do some screening. And in fact, in the geriatric literature around age-related neurodegenerative syndrome, they do recommend screening. And usually with something quick, like a 3-item memory test, maybe a clock drawing, or something that's really quick. So in the clinics where you're seeing 70-year-olds, you're not really looking for HIV-related impairment. Now you're looking for Alzheimer's disease or other neurodegenerative syndrome. And so you might pivot over to the guidelines that are coming out of the American Geriatric Society rather than the guidelines that are coming out of the HIV community. So I never can answer this question well. I think in older people, I feel like I need to do something. I think I would do something that's more aligned with Alzheimer's literature, something like a clock drawing and a memory task, because I'm looking for a more typical memory problem. But in a younger community, I don't think it's a lot of gain. I think monitoring function and challenges that people are having in the community and getting their work done is as valuable. And if people are missing appointments, they're not taking their medicines, then it's no longer screening. You're trying to find the reason why they have those symptoms, those functional changes. And I would definitely do something there. And the MOCA might be a really good thing to do there. But
right, so maybe moving on to the symptomatic patient. So if you are a provider and the patient comes to you and says, I feel like I'm having some challenges. I think there's sort of 3 concrete questions. Number one, what would be a test you would do in the room at the bedside? And it sounds like the MOCA is what you would use.
Yeah, for HIV, I think the MOCA, the MMSE is not good for HIV-related impairment. It's too orientation focus. It doesn't have enough attention, executive functioning. And the International HIV Dementia Scale, it doesn't work in treated people.
And then what about somebody who maybe scores poorly on a MOCA? You clearly indicated that you would refer such a patient. And I think there's some questions here in the Q&A, and I have the same question is, if you were going to refer, are there certain tests that you would order? So would you say, oh yeah, this person needs an MRI, this person needs formal neuropsych testing, this person needs an LP, that kind of thing? And to whom do you refer them? To a geriatric specialist, to a neurologist? Does it have to be a cognitive neurologist? What would you say?
Yeah, optimally, you would send them to a center that understands neurodegenerative and HIV-related challenges. And, we're lucky here. Every one of the clinicians working at my center can evaluate neurodegenerative syndromes as well as HIV. But no one, the vast majority of people don't have access to that. Right. So then it's a matter of finding community partners that have some confidence around this and maybe increasing their confidence in the diagnostics around this. I have a patient I'm very worried about here that is no longer in my research studies, and I recommended he see a geriatrician who I know is trained in this space. So it's very personal. I just know we have somebody who knows how to manage this, has a lot of HIV experience, but has really been thinking about the cognitive disorders and may lean on me a little bit for some stuff. That works fine. And then I have also, a patient who I was very worried about who was in another healthcare system that I had them see a general neurologist who did a fantastic job. So I think you have to really think about the competencies within your community and what's available. And it's hard to be dogmatic. I think it's more about what people's level of interest is on reading up on this and their, frankly, the humility in asking when they don't understand and willing to investigate and ask people like me that are willing to give second opinions.
And then, Victor, what about the question of cerebrospinal fluid and MRI imaging? I mean, if you're, again, seeing somebody, would you just wait and refer them and let the
Yes,
specialist make that decision?
I think these tests are really relegated to confirmation rather than diagnostics.
Mhm.
I'm loath to use a CSF biomarker. In fact, I have one patient who's got CSF biomarkers that are absolutely Alzheimer's disease. And yet I don't think he has Alzheimer's disease. And I've had to have a really uncomfortable conversation of, well, not uncomfortable, but saying, you may be in the preclinical stages and we could think about putting you on Aricept, or we can just watch to see how this progresses. So that's the way I see it, is you have to interpret these blood-based biomarkers, I think CSF biomarkers, in the context of a good clinical diagnostic. And if you're comfortable with the diagnostics clinically and you want to increase your confidence, and that is a space where I would use it, knowing that you have to interpret them. And that there's a lot of wiggle room in these things. They're not, as I showed you, there's a lot of overlap. So I guess approaching it with clinical confidence, wanting to have more is the way I use them.
Yeah, no, absolutely. Actually, I personally also agree with that. And I think that sending all of these tests and then having the information and trying to explain it to a particular patient in front of you really needs to be in the context of having a lot of knowledge and sort of the rest of the understanding. There's nice questions. There's several nice questions about sort of prevention. And Victor, you showed really nicely that Lancet diagram that showed all of the different risk factors for symptomatic Alzheimer's. So are there certain types of prevention methods that you would recommend? And, you know, some of the lifestyle methods, perhaps there's also a question about drugs or supplements. We have patients who come in, they've been taking certain kinds of supplements or herbals or these kinds of things. Do you have any thoughts on that?
Yeah, what I tell my patients is I have absolutely no evidence that any supplement works. Even the geriatrics group has pivoted away from having people take a multivitamin. Because if you're eating a healthy diet, the multivitamin is probably not adding much. And the vitamin D that everyone's taking is starting to get a little crazy. And we're finding that the big hopes of that and lowering hypertension and doing all these great things isn't panning out. So I'm reluctant to have people take the side effect of affecting their purse by buying these and feeling like they're doing stuff. So the supplement question is very easy to answer. I'll answer the other question from my favorite perspective, which is I'm not a member of your community, which is how I think of all my global work. So everyone, you know, we have people from 46 different countries that are here learning at any given time, and they're asking, what are the prevention strategies? And we look at the curve and what the Lancet has said, and then we think about all these different things, and then we have to think in the societal and cultural context that you're working, that your patient lives. How can they effectively address these things? So would you ask somebody in Honolulu, for example, to do I don't know, salsa? You know, no, but we know that there's evidence that gait can be improved with hula. So we have to really think carefully about how we're making these recommendations. And I think the one that comes up mostly is like, should I be having them pay $30 a month to do these cognitive tests online? Because that's where the market is now. And or the patient that came to me said, I'm doing Sudoku an hour a day. I'm going to make my brain strong. And I said, do you enjoy it? I hate it. I was like, so every day you're giving away an hour of your life? And so you can make your brain strong. What do you like to do? Well, New York Times crossword puzzles, we'll do those. You know, so I think you customize them to what works for the patients. I had a conversation yesterday with somebody in Nepal who, you know, very straightforward, like hypertension awareness, like it's asymptomatic, but it causes problem in your brain down the road. Let's do an awareness campaign. So we did the research literature, and there's evidence out of Nepal that says these awareness campaigns do not work. So you have to be really thoughtful about what you're doing and customize them for your patient population. And I'll say there's another even more interesting paper that was published 2 years later, showing that among low middle income countries, and I think within even our country, there are areas you might consider to be economically, socially, economically stressed in a way that's similar to these places. You can reduce this risk by 50%. So it really links to the attributable risk and the frequency of these challenges within your community.
So maybe there are many good questions in the chat again in the Q&A, and I think you know, some of these are being answered by our discussion. Maybe I'll end with one provocative one. So Victor, you showed the rates of cognitive impairment that have been published for people living with HIV on treatment. And then you suggested that you think in the aging population, it may be as high as 25% or even more. You also said that you don't screen necessarily, you wouldn't necessarily think of screening someone with HIV for cognitive impairment. There's a comment from Jules Levin in the Q&A noting that the IAS-USA just published guidelines that recommend that everyone over 50 who's living with HIV does get cognitively screened in some way. To me, that seems a little commensurate with what you were talking about. You're talking about higher risks in people who are aging. What do you think? And if you think that makes sense, how would we implement that?
Yeah, so the reason why I don't screen is I don't do primary care. So don't get the wrong message there. I'm not telling people in primary care not to screen. If I were in primary care, I think the second part of my question is where I was at. Like, I'm struggling with this question. That's where my head is. And there are guidelines that are saying you should screen on a regular basis. There are others that are saying, and sometimes they don't get published because negative things aren't, as well known. That there's not enough evidence that this is going to have a meaningful impact on people in the long run. So to me, and then I think the other thing I was adding, Dr. Spudich, is that once you start getting into older ages, you're not just thinking about HIV, you're thinking about non-HIV. And there the data, there's more consensus that we should be screening in those settings. So I think I'm with Jules that we should be screening. I don't know, 50 is a little young. I'm 57. Let me get into my 60s and recognizing that these symptoms may present earlier in people with HIV. So I'm leaning on the fence of these guidelines as well. And if I were in primary care, I'd be really scratching my head and probably asking why I'm not doing it. And then I think I would do something that's a little bit short and simple, as I said. And then if I find concern, if people are symptomatic, I'd probably do the MOCA. But if they're not asymptomatic, I'm just like trying to check, I'd probably do maybe a little trails, some memory, and I'd make something up, a clock, myself, just to get a sense. And if that's all good, let's see you another year, or something that's not taking quite 8.5 minutes, which is a lot of real estate in a 15-minute appointment, but maybe, takes 3 to 5 minutes. And then if somebody doesn't do well on that, or they have symptoms, I'd probably do the MOCA, if nothing else, to get a baseline. And if you do have time in your clinic, if your patient appointments are once a year, you get an hour health appointment, get a baseline, do a MOCA, do something to get it in there, and then you'll be in a better sense, moving forward. Sorry, I'm incredibly practical about these things, and sometimes I make people really angry because you can't be too dogmatic about things when the data aren't that strong. Yeah. And I'm not the one in the primary care clinic dealing with the many challenges that people are working through. And so people in the clinics may be in a better place to prioritize what they can accomplish and still have a healthy life.
So we still have 170 people on the call, which is amazing. Dr. Valcour, I do think that we've run over time. So I'm assuming that it means we should probably sign off. Again, there are some fantastic questions. I think the fact that you've highlighted that there's this potential overlap in these syndromes that you can't necessarily differentiate based on MRI imaging, based on cognitive testing patterns, based on symptoms. Perhaps some of the CSF biomarkers can be informative. It's only getting to something like what's now mostly research indications of PET imaging. But I think it's really important for us to know, not only in terms of managing and treating our patients, but also I think from a research standpoint, thinking about what some of the major research mandates are moving forward, right? Is really being able to collect some of these biomarkers where we can inform our patients about some of these diagnoses. But I think this was a fantastic talk, and thank you so much to the audience for all the wonderful questions. And I'm hoping, Jose and Donna, that these can be available to Dr. Valcour going forward, so this can inform his work.
Yeah, and we'll definitely be able to share the questions that we gathered from the audience. I'll go ahead and take it from here, Dr. Spudich. So again, thank you, Dr. Valcour and Dr. Spudich, for an excellent presentation and discussion on this topic. As a reminder for our audience, evaluation and information on how to claim continuing education credits will be emailed by 5 p.m. Pacific time tomorrow. And this will enable us to review all of those that have attended today's live broadcast. Your feedback and evaluation is very important to us, and it'll help us continue and improve the delivery of our program. So we highly encourage you to complete those evaluations that we send out. Next week, we have a webinar on breast and chest feeding among individuals with HIV. For information on how to register, please visit our website. We have 2 upcoming courses for this spring. Again, for more information, please visit the IAS-USA website. We continue to schedule our COVID-19 and emerging virus outbreaks dialogues. For information on that, visit our website. And lastly, registration is open for CROI, which will be held in Seattle next month. And for information on that, please visit the CROI website. All right, again, we'd like to thank our audience, and this concludes today's presentation. Thank you, everyone.
Thank you. Appreciate it.